Hello, everyone. My name is James Klinger. I'm a pulmonary physician at Rhode Island Hospital and Brown University, and I'm here today with Dr. Robert Frantz from the Mayo Medical Clinic. Dr. Frantz is a professor of medicine in the Department of Cardiovascular Diseases, and he's the director of the Pulmonary Hypertension Clinic at Mayo Clinic. Thanks for joining us today, Bob.
Hey, Jim, it's great to be here. Always fun to chat.
Today, we wanted to talk about making the best choice for the individual patient, and I know this is kind of a luxury that we have now that we didn't have before. I remember when you and I first started seeing these patients, we didn't have much in the way of choices because there was only one or two medications available. But now with the approval of over a dozen medications, there's quite a bit to choose from. So can you tell us a little bit about how you go about making the decision about what medicine is best for which patient?
Sure. We have talked previously about prognostication and functional class and RV function and brain natriuretic peptide levels and 6-minute walk distances and things like that. But such a broad number of patients may fall into sort of a intermediate risk category where you could be a little bit more conservative in your choices in terms of aggressiveness of care or a little bit more aggressive. And in addition, for a typical functional class 3 patient with some RV impairment but not clearly needing parenteral prostanoids, we really do have quite a number of choices to make. And when we think about the concept of patient-focused medicine, we're sort of thinking about the idea of not only looking at the patient as having this disease process with a certain severity, but also thinking about the person and what their views are of their situation and their disease process. And so we often lament the fact that of patients who pass away with pulmonary arterial hypertension, about half of them are not on parenteral prostanoids at that point, which has been taken as a way of saying that we're underutilizing parenteral prostanoids. But the context is often missing in that discussion about knowing whether there was a discussion about the use of parenteral prostanoids and that the patient chose not to go that direction or didn't tolerate them or had been on them and decided to stop them. And so when I think about strategy in patients in terms of degree of aggressiveness, I kind of think about the concept of some investment manager coming to talk to you and saying, are you a conservative investor or an aggressive investor, and what's your risk tolerance? And in a way, with a patient in a given circumstance, we need to get to know them as people in the sense that where are they in their life journey with regard to not only young to old, but also goals of therapy. And if they're a 30-year-old woman with 3 children under the age of 10, then often the goal is to live as well and as long as possible. If they're 82 with scleroderma, some pulmonary fibrosis, and difficult to deal with scleroderma complications, who also have PAH, then even if their hemodynamics are quite off, often the idea of parenteral prostanoids is just not something that's going to be in their interest. And so to me, that's the first step in individualized choices in therapy, is getting to know our patients as people and where they think they are with regard to their decision-making. When I think about things further in those patients where they're probably maybe not in need for parenteral prostanoids and there's a decision-making process, I often think about their comorbidities and their symptom complex as they're coming in. And one example is that when we have a patient who might be on dual oral therapy with a nitric oxide pathway drug and an endothelin receptor antagonist who needs something additional, then the issue is, are we going to go with something like selexapags, an oral IP receptor agonist, or inhaled treprostinil, or some other possibility? And I think that if the patient has a big problem with migraine headaches or tends to get headaches very easily or is very sensitive to medications, sometimes we might talk about an inhaled medication. If they're trying to juggle a busy lifestyle, then 4-time-a-day inhalation may not be very practical. So it really takes time, and often we have our nurses do some of this work as well of going through treatment options with people and letting them reflect on it a little bit before we make a decision about it. Other thoughts that you have about that process, Jim?
No, I really like your analogy to the financial investor, although I have to tell you, whenever they ask me questions, I always say, well, I want to make the most money possible with the least amount of risk, because I always think there's one choice that will get that for you. And I think that's one of the problems that the patients have as well, is when we explain all the options, frequently they end up saying, give me the medicine that's most likely going to make me better and is easiest to take and most affordable. And unfortunately, I think with the PH medicines, it's difficult to get your cake and eat it too, particularly when we look at the differences in responses to parental prostacyclin therapy and the oral medications. So I think your analogy is right. You have to decide how aggressive people want to be with their treatment. I frequently say that, unless they have advanced disease or they're highly symptomatic, that it probably makes sense to see how they respond to the easier therapy, which is usually the oral therapies, with the idea that if we don't get the response we want, we're going to try to ramp it up to something more aggressive. Nowadays, it's amazing what these PH patients are doing, and I've been very surprised sometimes when you sit down and get to know these patients better that the drugs really can impact their lifestyle in such a way that the type of medicine they use can be almost as important as the treatment response.
It's absolutely true, and for example, with inhaled prostanoids, they're just complicated enough that when they first came along with that concept, it just seemed that it would be a nice way to deliver a drug, which wouldn't have so many systemic side effects. But from a practicality perspective, the concerns of patients about using something 4 times a day have been greater than I might have expected, honestly. And so we really do have to think about those issues when we think about which medications for which patient. I suppose the other thing is that patients always say, well, what will provide me the best quality of life? Because that's really what I'm interested in, is quality of life. And so there's a trend in recent years to be thinking more about measuring quality of life with various instruments. But there's not been very much data about that in the pulmonary hypertension literature, which is now starting to expand, about how that really relates to their disease state and their outcome. And I was encouraged in that regard to see a paper by Steve Matai at Johns Hopkins, published in the Annals of the American Thoracic Society back in 2016, that was looking at the SF-36, which is sort of a generic quality of life instrument in newly diagnosed PAH patients at Johns Hopkins, and showing, of course, that there was substantial impairment in their reported quality of life on the various scales, and that it, in fact, correlated with their 6-minute walk distance and tracked also with outcome with regard to survival. So that was nice to know, because we didn't really know that much about how quality of life instruments track with outcome. And then if you treat somebody with a PAH medication and they improve their scores, then in fact it tracked with better outcome as well. So in a way, that's a win-win, where if we think we have therapies that both improve outcome and also improve quality of life measures, then we feel like we're congruent with regard to not only giving a therapy that protects RV function and survival, but also enhances quality of life. But now clearly it's incumbent on all the clinical trials of drugs to look at this. And in this regard, one thing that does concern me some is that the use of quality of life instruments in clinical practice is actually very low. And so this is a thing where I think we might be able to improve that, where if we make decisions with patients, we talk to them about their experience and how they're doing, which is terrific. But if we also have objective measures over time of a quality of life instrument, then we might have a little bit of clue of how well we're doing or not doing with our therapies, and maybe that would better guide treatment decisions, aside from just talking to patients subjectively about how they're doing.
Yeah, I think that's a great point. We have a lot of data on how well the medications improve hemodynamics and functional capacity and things like this, but we really have very little on how the medicines impact negatively. So, it'd be kind of interesting if there was a scale of 1 to 10 and you knew that a parental prostanoid was a 8 and an oral therapy, monotherapy was a 2. then you could use that as part of your, risk-benefit ratio. But I think we probably underestimate how much of a negative impact some of the therapies have on patients' lives just because they have to take them so often.
It's true, and I'm not sure whether the quality of life instruments we have exactly measure the side effect burden as well as we might like, and so there's sort of these areas that we need to continue to learn about. There is a newer tool that's come along, which is the PAH symptoms and impact tool, called the SIMPACT, that is a potential instrument that's been validated now and just recently published in CHEST in that regard, that is a sort of derived in congruence with the FDA regulations on development of quality of life instruments. And so that's an instrument that potentially would be available both to researchers and clinicians for use in clinical practice and also in research, which could be interesting to see how we're doing. And maybe a quality metric for us in our practices is whether we're looking at quality of life and whether we're able to move the dial on it with our therapies.
Yeah. The other question that I get frequently is that when I start to explain all the different medications that are available, many patients become impressed that there must be one or two of those medicines that is better for their particular condition than the other medications. Is there any way that we can help patients understand what medicines might be better, or explain to them that maybe we just don't know if one's better than the other?
Yeah, I think you're really getting at this whole hot topic of precision medicine and trying to truly individualize care based on genotypes or other markers of disease. And I think that area is exciting, but also kind of in its infancy with regard to that process. For example, Ray Benzit published some work on various polymorphisms that impact the endothelin pathway as predictors of response to an endothelin receptor blocker. But a lot of these polymorphisms aren't really common enough to be really clearly useful in clinical practice and often aren't really available that way. So it's been difficult to really find predictors of response. And we talked about this a little bit previously on another discussion about the efforts to figure out which patients might respond better to riociguat than to a PD-5 inhibitor, and it's just been exceedingly difficult really to do that. And so I think one example of the continued effort to go that direction is the Pulmonary Vascular Disease Omics NIH project, of which I'm an investigator along with a number of other centers across the country that is doing proteomics and genomics and metabolomics across pH types, and is the type of work that then, when correlated with very careful clinical phenotyping, maybe could start to talk about that, and the goal being to try to do better with regard to precision medicine, of looking at ultimately who responds to a given drug and then trying to relate that back to a particular pathway that is involved maybe in drug metabolism or has some marker of the vasodilatory and vasoconstrictive state of the patient. Unfortunately, right now, from a practical perspective, there's just not that much out there that's really useful. I do think that serial BNP or NT-proBNP levels as kind of a canary in the coal mine of response is useful, where if we do something with drugs that brings those values down, along with looking at other measures, I think it's pretty reassuring. So if I see a patient whose BNP levels come down from pretty high to pretty close to normal and is staying there on a therapy, and they ask me, do they need more therapy? I think a lot of the time the answer is no, and as long as other things are tracking that way. So I think that's one biomarker of response that has been useful to me in making decisions along with other parameters about whether to escalate therapy. In a broad sense, I think that older patients who have heart failure with preserved ejection risk factors, I tend to shy away from endothelin receptor antagonists as first-line therapy because my experience is that they tend to not do as well with them sometimes in terms of volume retention and other issues, and I'd be more likely to start a PDE5 inhibitor in that patient group. Other thoughts you have about this idea of precision medicine and making choices on an individual basis for our patients?
No, I think you're right, Bob. I think right now we just don't have the data to actually demonstrate which drugs are going to be better in which patients. And as a result, the thing that I think is important to keep in mind is to make sure that your patient either, one, gets better in response to a particular therapy, or that they have an opportunity to try all of the presently available therapies that are available. Because I am convinced that there are some patients who respond better to some therapies than others, even though we can't identify a priori who those patients are.
It's absolutely true, and it's part of the art of medicine, I suppose, and also, of course, the reason that we're so careful in following these patients longitudinally so that we can be reactive to their changing circumstances and response or lack of it.
Right. Well, Bob, I think this has been very helpful, and I appreciate your comments and taking the time to join us today for this discussion. Thanks very much.
My pleasure, Jim. Hope you have a great rest of your day.